Hello, everyone, and welcome to the Practice Perfect podcast. We are here with episode 8. It's a beautiful day. How are you, my lovely co host, Maya Turner?
I am so excited. We got an hour of extra light. The sun is shining. It is 60 degrees. Oh my gosh. It is spring is in the air, literally. So I'm very excited today.
Me too. And Maya, please tell Chicago to hold on for me because I wanted to stay nice when I'm there in a couple weeks.
Oh, I promise I'll make sure the groundhog does not give us any more additional signs of what could possibly be. So I'll definitely keep that on the watch.
Okay, I'm very excited. So, really good stuff coming. So we're excited about our guest today, and so we're not gonna add any more fluff to this episode. We're gonna bring on our amazing guest today. So I want to welcome to the show. We have Robin Ingalls-Fitzgerald. So, Robin, welcome to the show.
I am so excited to be here, ladies. Thank you so much for inviting me. Maya, I'm jealous that you have 60 degrees. I woke up this morning and it was 28.
Oh,
So, yeah, the groundhog isn't being so kind and gentle yet in New Hampshire.
I
Yeah,
apologize for that, how you woke up this morning. That's not
yeah.
fun at all.
You live in northern New England, you get used to the cold. So,
right,
but,
exactly.
Yes, and
but
I
I
think
really appreciate you inviting me here. This is wonderful. And I'm looking forward to our discussion today.
absolutely. Well, I've been to the Northeast in New England. I was just there late last year, and my husband and I had a great time. We went to a conference, and then we just jumped on over a plane and decided, well, we're over that way. Let's just enjoy Boston. And so we enjoyed our vacation in Boston so much.
Wonderful. It's a great city.
Yes, it's one of the best. And I think that, of course, the highlight was the reason we went was it was my anniversary present to him, Red Sox tickets. So he finally got to hit Fenway and he got to meet one of the players and he was just like just on cloud nine. So he just had a great time. So I'm glad we got to do that. So yeah, good times. I love to travel. I know I do it a lot, it seems lately. And I get to travel and see Maya in a couple of weeks with one of our shared
Nice.
clients. And I don't know, do you guys ladies, do you like to travel? Like, where's your favorite place you've ever traveled, Robin?
Well, I love Chicago. I used to go there to the CPT symposium. Great city. And they now do just virtual, which is kind of sad because I would meet all my coding peeps and we would have a great time and we would
Right?
take some shows and they don't do it live anymore. They do it virtual. And I really wish they would bring it back because I spent
You're not the only one.
many Novembers in Chicago and loved it.
Yeah.
Of course, Boston, love Boston. I'm heading to DC next week, this weekend actually. So, yeah, I love to travel. Looking forward to traveling more abroad. Had a beautiful trip planned to Japan in 2020. Yeah, and March of 2020, I was going to do a 2-week whirlwind in through Japan, but then haven't had the opportunity to reschedule that yet. So it's on my list of things to reschedule. But I love
Excellent.
traveling.
To go back to Chicago, right? We have the best food. We have
Mm.
the best variety of food, the best origins of food, and yeah, that's why a lot of us here in Chicago have big backs, and that's okay because we like having big backs.
Yeah, the food's good in Chicago. The food's really good in Boston too. The food,
Oh well,
Oh my
of course.
goodness.
So we need to make a trip to Boston, Jen. We got to go over to Boston to see what's going on in Boston. You've already gone, but maybe we can get some more clients in Boston so that we can go visit.
yes.
Yeah, I'm
You
saying
guys come
everyone
to
out
Boston, I'll
there,
come see you.
yeah, just plan a conference, guys. Are you listening to HEMA or APC? Boston, Boston. Make it happen. So yeah, love
Actually,
it.
I'm not trying to step on you there. Actually, in the AHEMA conference in Salt Lake, we lobbied AHEMA to bring it to Boston in 27.
What?
Exciting.
Nice.
We are
So
lobbying
Well,
to bring it to Boston.
it's almost as if
that
they
is
do the
good.
conferences in like the same areas, right? It's always the same areas because wherever someone goes to Las Vegas, it's more than Las Vegas. If someone goes to Orlando, there's more than Orlando. So there's a pattern there. So I'm with you, Robin, on that.
Yeah. I agree. And so, yeah, I mean, like with HealthCon, they finally brought it back to Orlando. It was in Orlando for so many years, and now it's coming back. So I kind of hope it stays. I mean, I love my Florida weather when I need it. So it's nice to get
You
to back.
like palm trees, right?
Yeah, I just love everything about it. So, well, let's talk about why we're here today, ladies. And that is, we want to dig in and learn a little bit more about Robin and what she does and what kind of all of us do. But Robin, how did you get started in healthcare, and what are you currently doing and your passion lately?
Well, fun story. I originally was going to be a nurse, and I got accepted to nursing school and couldn't get any funding to go. So I stumbled across coding, and I had this idea. I started coding in '95, and I had this idea of helping out practices because, hospitals have coders, right? They have all these wonderful certified coders who do all the inpatients and the day surgeries and all that stuff. But practices, as a rule, did not have coders. This goes back to '95. So I had this idea in '95 that, maybe I'll open a coding company for practices. So time warp to March of 26. So I'm hitting my 19th year anniversary of my company. I ran down to my bank with $100, registered the business in the state of New Hampshire, and boom, I had a company. My original plan was to help practices, but because I had so much hospital background, I started picking up outsourced coding for ERs, and ERs was my specialty. So I started training people with ERs, and then we started doing auditing, and within the last 5 years, we got into the software plane, and we now have got 2 platforms. One's an auditing solution to help, what we're talking about today, quality assurance, quality of the documentation, basically quality all around, and kind of knowing yourself on an auditing plane. So our platform allows you to put all your data in there and gives you a quality score without having to do it all on a spreadsheet, and it keeps it coherent across the auditing platform for you as an auditor, and somebody comes in behind you. So like, say, Jennifer, you were auditing a chart and you won the lottery and you didn't finish the audit, you went living in the Bahamas, Maya could pick up where you left off. So that's kind of how our tool works. And we have our second tool is a revenue cycle, all around revenue cycle, KPIs, and in just 835 files, I and P, and gives you quality checks and balances and tells you how the payer's paying and deductibles and all that type of stuff. So those are our 2 platforms in addition to auditing and coding.
Mind blown. It's a great product, guys. Jennifer and I have used it, so it's just wonderful. So I can't give you enough kudos. I mean, you run the gamut, and you know the intricacies of what makes it a great product. So definitely.
Thank you. Yeah,
Agreed,
I enjoy
agreed.
it.
Yeah.
Yeah, so I enjoy auditing, because a lot of people think, when you're doing these quality checks, that you're doing it to be punitive. And the nice thing about our solution is you can put in positive comments, so it doesn't have to be punitive. And when people think you're reviewing them, they're thinking you're doing it because they're wrong, and you're really not. You're doing them so that in coding, right? We change every year. In October, we changed the diagnosis code set, and come January, we're going to say it changed the HCPCS and the CPT code set. We really, as coders, need to constantly stay in tuned and abreast of what's changing. I mean, I'll use telehealth for example, right?
Mm-hmm.
Yeah, those new. Yeah, sorry to torture you, Maya. Right? And so telehealth, they changed the codes in January, but now CMS is saying, well, we're not sure we're going to pay for those. We're going to still do the E&Ms. And they're saying they're going to give us an answer by the end of the month, and we got 2 weeks left.
I know, it's always down to the wire, isn't it?
Well, I mean, we want the suspense, Robin. What are you talking about?
We love the suspense. Yeah, we love the extra stress in our lives.
Exactly.
Seriously.
And what to tell our clients, like, really, we're this is what we have, right?
Yeah.
So,
Yeah,
we
it's
just put the
funny.
face, the mask face, right? Like we don't know what's happening, so we all just put the face, like the face that we don't know what the big emoji and that big question
Yeah.
mark, right?
Uh-huh. Exactly. It was funny. I was on another Facebook group, like one of those group Facebook groups where your community gets on there and tells what's going on in the community. And somebody went on there and was talking about telehealth. I'm like, did you guys know this? And like they were just putting on there like they had heard about, like I didn't even know there was a thing that it was going to go away. Like they were just like, they just ran across this post on Medicare and they were like, what's going on? And so I think that there's a big interest, even with just the public getting this information from wherever they get it and not really understanding what is actually happening and how it affects them individually. I've had conversations with friends and family and just people always ask me questions about different things. And so I try to send them to the right resources, the direct source of information. Maya is one of my direct sources of information for telehealth because it's not something I deal with on a regular. So,
Oh my gosh. And what's really
but
sad about the whole situation about telehealth
yeah,
is that you have a lot of businesses who have been created for telehealth alone. And the fact that they're doing this and they're not focused on the three main areas that can perform telehealth, regardless of origin, it makes it so sad because that's where they were getting their money from, and now it's going to go away. And it's just like nobody's hearing how this is helping so many people, even though they think that telehealth is just an audio video piece. It's also audio alone, and nobody's considering that factor and that piece to help a lot of people who don't have the ability to get the audio video. So it's just a really bad possibility that could affect a lot of people.
Oh,
you
absolutely,
know,
absolutely.
absolutely. Yeah.
Especially where I'm located. I'm located in rural New Hampshire, so telehealth has really been beneficial for small clinics and small town docs who need to get an expert in to see the patient, but the patient can't travel 2, 3, 4 hours to see a specialist.
Wow.
So
Yeah.
you're talking, we're talking communities that are like on the Canadian border that would have to
Oh
drive
yeah.
miles to see a specialist.
Oh,
So
Robin, girl, I could talk to you for hours, for days about that. I promise.
yeah,
And I'm like bursting at the seams. Jennifer knows such a ding. So I'm trying to
Well, maybe
not
we'll
say
have
a
to
whole
have
lot.
another chat about social determinants of health and all that good jazz.
yeah. And
So,
then getting providers to document.
oh
Oh,
yeah, there's another topic right there.
Robin, stop it.
Well,
Stop it.
that kind of dovetails into what we're going to talk about today because let's just really talk about quality assurance. I know we use that terminology in the past and now we just say audit, but really that's what auditing is. I mean, it
Right.
is intended to be a QA kind of thing. So back in the day when I was work for hospitals most of my career, and then I decided to go out and work from home. I tried to find a way to get home eventually because I wanted to work from home, and so I found some work there, and so I worked as a coder, and then I also worked as a QA simultaneously. So I coded for one physician practice, and then they put me as a QA for somebody else. So it was kind of nice. Like you had your coding world, and then they would switch you. And okay, for this client, you're going to go ahead and you're going to QA this coder, and then they would QA you. So it was kind of cool. Like we always knew there was some kind of checks and balances. Whatever we were doing, somebody was always checking us, right? Just to make sure, because we're not perfect, right? So we're going to make mistakes. And I think that is a piece that's missing is that it's not that we don't trust our staff, it's that we know their human element is there. And we may not always grab what someone else might grab. So it's nice to kind of see the differences in how different people pull information. Now you may not always agree with your audit, and that's completely fine, right? We understand there's a relationship between coding accuracy and then actually what is payable, right? So we have to make sure we understand all the pieces, and we may not really get it. And so we need to have the extra backup. So, Robin, to you, what is the best way to approach quality assurance or auditing nowadays? Like, what's the right approach right now?
What I do with my clients is I again I make sure that they're aware that all of these changes that take place everybody's not going to know, like you said, you're human. So I would
Mhm.
approach the client and say, first of all, above all, the OIG actually, and for those of you who don't know the OIG, it's the Officer and Inspector General, requires anybody who takes a government payer, Medicare or Medicaid, that you self-audit every quarter. A lot of facilities don't know that. So a lot of my facilities use us as their internal auditing service because they don't, again, small rural hospitals, critical access, we're really big in the critical access community. They don't have a person who has that expertise to audit their coding staff and or their providers. So the OIG has this ruling, so we come in as their internal auditor, and then they hire somebody to come in and be an external auditor. So we'll do an internal audit, and they'll have an external audit, et cetera. And a lot of times, like a coder just didn't know the rule change, or the provider decided that they're not going to audit me if I give everybody a 3. You know, and even though that they have the level 4, but like I'm gonna just everybody's gonna get 3 because then I can fly under the radar and everything's great. So we educate after we do the auditing and talk to these providers and coders, we give them feedback, and then they have that line of communication because, like you said, not everybody's gonna know everything. I mean, I have a list of phone a friends that I will I got this question, I'm not sure. I send it out to
Yeah.
whomever I can. And in the world of coding and auditing and quality, you really have to have a village. You have to have a tribe around you, because I can know something in my that I can bring to the table, but maybe what I don't know, I can go over to Maya, or I can come to you, Jennifer, and say, hey, I don't know this. Do you have you seen something in your state? Because this is what we're seeing in the Northeast. And that network is priceless. It's just plain priceless.
Mm-hmm. Absolutely.
I
You
would
know,
have to
we.
say, go ahead, Jen.
I was just going to say real quick. We can't go into this in a silo. Like we're the only one that has this information and not share it. There are some people out there who like to hold tight to the chest on what they know because they feel like that's their only way to survive. It's like that's their survival technique, but that's not the way to be.
I was going to also add that, because it's medicine, right? And there's a village of medical specialties and physicians talk to each other, right? You have other coders who have different specialties, just like the world of medicine. And in order to create a care team, you have to have a care or a specialty that is all involved on the same team. And that's the same with coders, right? For coders, you have to have a team that specializes in different things, just like in the world of medicine. And if you look at any hospital care, you have a team of providers that specialize in different things. How is that different from coding? It's not. And the only way that you can get a common goal, which is the outcome of the best quality, you have to have a team. You have to have a great team, and you have to know who to call and when to call
them. Yep.
Who are you going to call?
Literally takes a village.
Yeah.
Okay, I'm sorry.
I love it. No, I mean it's really, really important. And nothing against companies that are multi-specialty, because that is a thing. And I am technically multi-specialty in my career because I have worked in many specialties, but I don't claim to know all of them. And so even if you are a larger auditing company where you have multiple clients, that's great. But just make sure that people working on that audit, you can validate, have the experience and the expertise. Because when you're claiming to a client that you have the experts, you better have the experts and produce them when required.
Correct. And,
yeah.
And the other thing I was thinking about quality, a lot of times people in our world, in the revenue cycle, auditing, coding world, do not get enough credit for the quality that the hospital gets. Everybody thinks that the hospital's quality score is based on the treatment that the patient gets. It also gets on the documentation that comes down to coding, that goes out on the bill. That quality chain going from the minute that patient goes into the facility till discharge, and what happens on the back end, that's all part of that quality and quality score for that facility. So a lot of people don't realize the importance of that whole HIM and patient financial services, because they're the back end, the buck stops there, but a lot of people just don't realize the importance that a role that coding, billing, et cetera, plays in the whole ecosystem of the hospital. A lot of people just don't understand that process and don't understand the importance at all, sadly.
You know, I was going to
Unfortunately.
say, Robin, that is so important. And I was just speaking on with HICA and you comply, the importance of the revenue cycle, right? And when you're dealing with compliance and the revenue cycle, it's all about that circle. It starts at the scheduling, it ends when it's posted. But at the end of the day, you have the patient, which is in between every one of those circles, right?
Yep.
And the end of the day, you really have to understand that the revenue cycle and the patient responsibility and the viability of that responsibility is going to increase patient satisfaction, whether they get the bill, whether they're treated well, whether they have a complication. All of that makes a difference based upon the quality, the auditing, and the outcome of how that claim is submitted. So I couldn't agree with you more. That's so relevant.
Absolutely. And, I think about the fact that coders and billers, I mean, they're like one of the first people that actually see the documentation, because after the physician documents, they don't want to look at it again necessarily right away. Like, they document it, it's signed, it's done, right? Then it goes off to the people to get them paid for what they've just done. So the coders, they kind of see it first because it's passed off to them. Now, maybe the clinical teams will look at stuff just because they have to send orders and things like that, and they have to send, records for things. But they don't always look at them. They're just looking for the right document. They don't read them. They're just passing it off because they need to get an authorization or whatever. So coders actually read the documentation. So when you're looking at quality of documentation, accuracy of what actually happened to your patient, your coders are the ones reading it and feedbacking that to you, saying, hey, this is a little inconsistent here, right? This is not quite right. Can you clarify this? Because they know, not just with the insurance ones, but they know from a quality standpoint what needs to be there overall because they've been trained.
And, I wanted to add too, and Robin, I mean, and I know that you are aware of this, but there are times, especially when you have, like, I'm talking from a facility side, right? When you're talking about the charge nurse and those charge CDM codes that get sometimes transposed, right? Mm-hmm. Or misinterpreted the 1 unit to 10 units, right? And it's just a keystroke. And that's the difference of the patient being charged, one price versus another price. So when you think about the quality perspective of that and that alone, there's a world of inpatient workflows that need to be addressed that I don't think is addressed as much. That's why you have companies like for Jared's company about those charges that are excessive, because there's nobody looking at the quality of the CDM or the charge nurses for that revenue bill that goes out. And it's, instead of it being 10,000, it's 100,000 because of a keystroke. And that really needs to be a process that is addressed, that I don't think is addressed the way that it should be, but there's a lot of opportunity there for the CDM and the revenue codes to be addressed in a manner that is appropriate, especially when you're dealing with surgical suites and those surgical charges. That's insane. I've seen some things I'm just like, this is not right. But again, you don't know, because you don't know what the CDM codes matches and if it was a keystroke error or if it was accurate, because there's no auditing involved with that.
True. And a couple of times we've done charge master audits, and it's really good to audit the whole chart. So it's more like a revenue integrity. So when you're doing these quality checks, you're really doing a revenue integrity check as well. You're looking at what was charged, how it was charged. Like I've got some clients that are able to pick up on that keystroke error and say it was supposed to be 1 unit and they charged 1,000 and the bill was like, bazillions of dollars. That's something you can catch quick. But sometimes you don't catch X2 here, 1 there. So revenue integrity is like the big buzzword now. Everybody's talking about, let's do revenue integrity. But that also ties into your quality checks, and it ties into your auditing, and it all ties in together. And I do a presentation on self-auditing, and my first slide that I come up with is a comment from Aristotle that says, knowing yourself is your best defense.
Oh, wow.
So really, It's just knowing what your facility is doing and not looking at it as punitive, but as a quality measure to improve your organization and the patient care of that organization to the patients who are coming in your door. So it's really, really, I feel that quality is something that is extremely important for any facility if they really want to take care of their client base and their patients, because that's the patients there. Then they're not going to get reimbursed if the patient decides that they're not going to go back to their clinic because it was bad treatment, and there wasn't good quality. They will go back because they were treated fairly and they had that quality care, including down to the bill. So it's a cycle, right? Patient comes in, patient leaves, bill goes out the door, patient leaves, everything's great. So it's important to have a good, strong, quality organization from start to finish, so that at the end of the day, the patient's care was paramount.
Absolutely. And I think too, when we think about the process of auditing, why we audit even more so now, look at where we are. Look at how many errors we're seeing across the board. Look how since 2005, we're still seeing astronomical modifier 25 issues, modifier 59. The OIG did those audits like 20 years ago. And we have more issues now. And so it's about, we look at the coders, people are understaffed. They don't have the people they need to keep up with the volume.
Right.
And so that's why, of course, your company and ours both kind of work together, because we outsource. We're kind of like what I call outsource to insource. So like we like to help practices with their volume, because you need quality people that can just get that extra stuff done so you can focus on patient care. But I like to really take over for your staff. We just like to support your staff. So I always tell them, we're not taking over for your coding unless you want us to, but we're really just there to support you and like just make sure your staff has what they need. They understand, how to maneuver through some of these payer requirements that they may be familiar with. So we can give them education. We can also train the staff to take over the coding and billing when they get to that point, if they're not quite up to par. So we can help with all of that. So I think that's the key, is having those collaborations like with you, Robin, and with others, that we can say, hey, we're here to help. We're not here to kind of take over, but we can in the event that that's a necessity. And it's all about compliance. It's making sure it's accurate. How many times have we looked at a note and we see they did the right hip and they put the left diagnosis? And how many times have I seen that in orthopedics? And I'm just like, it's a minor issue, but it can be a big problem down the road for compliance. So it's not something you just gloss over and be like, oh, I know what it really meant. They meant to say. They didn't say it though.
But I also want to go back to, Robin, I think all of us, on this, podcast, I think it's important to not only recognize that there's a problem, but we also have to give, shout outs to the organizations or the physician practices who are welcoming the input.
Yes.
A lot of times, they realize that something is wrong. That's where they're seeking help. But big shout out to Fox Valley Medical Associates, where we're coming out on the 26th. Not only have they recognized that there's a problem, but they've been welcoming to the education and the takeaways for what's being learned. So, it's dual-sided, right? You have to have the knowledge, but they have to be willing to accept what you have to teach, or what needs to be corrected. And if they don't make the correction, then they're back at the beginning and they're wasting dollars. There's no return on investment. But I think it's very important as a whole that to recognize that providers, one, have to seek, and then they have to learn. Once they seek and learn and they take away, then it becomes a vetted process and it becomes a partnership rather than a, auditing type of deal.
Right. And one of our internal teams.
Go ahead.
Oh, no, go ahead, Robin.
One of the things we pride ourselves here at MRS is we tell our clients that we are an extension of their workforce. We are not an outsourced company. We are as if we are sitting in your chair in your organization, working beside your billing, coding, et cetera team. So we are that is one of the things that every one of our clients have access to me, and if they need to question answered or anything, they can come right to me. But we really pride ourselves in being that extension of that workforce, and that we're not just an outsourced quote unquote company. It's kind of like the term in-source. I thought that was pretty cool.
Yeah.
But that was kind of like what we do that because, and our clients are happy with that. They like the fact that we are vetted into their organization and that we're not there just to get paid and, and not offer any kind of support. So it's one of the things we pride ourselves in.
Yeah, I mean, we're a service company. I mean, we're a service industry regardless. I mean, everyone in healthcare is part of the service industry. We serve others. We don't serve ourselves. And that's why we love healthcare, because that's the reason we're doing this. We care about people. And if we're here for other reasons, then that's a deeper issue. But again, we want to make sure that we're thinking about the people that are involved in this. And so that's why we audit. That's why we care. And we want to make sure things are accurate, because what if it was our chart? I look at it and I'm thinking, like, what if this was me? Like, if this was my record, what would I see? And I have had friends like show me their record, and their physicians have billed a level 5. And I'm like, I can see right away, this is not a 5. And then sometimes I see where it could have been. So I see what could be, because it was just a minor, like, I know what they meant to say, but they didn't say it. And so they've just kind of shot themselves in the foot. They could have gone from a 4 to a 5 very easily because of the comorbidities and because of the treatment plan, but they missed an element of specificity that needed to be there to prove to the insurance company that it truly was a high level to be reimbursed that way. And that's all we're asking for is to let us train you. We know how the insurance thinks. We're inside their heads. And so we know what they want. Yeah. But you know why we know what they want? Because they've told us what they want. And sometimes they aren't as clear, but we know how to go to the next level and get the information where they don't have time for that. So come to us, let us tell you what needs to be done, and then you can just do it, and then you can move on. And it's golden.
Absolutely. You know how you hear the saying that if it's not documented, it didn't happen? You know what my favorite saying is? Documentation is good patient care.
Yes, it is. And, I always say sometimes there's things that aren't reimbursable. So they'll ask me, and it's like, you know what? You really took care of your patient right there. It's not reimbursable, but I'm so proud of you for taking care of your patients.
And not everything is reimbursable. So you want to allow the patient to get quality patient care. And I'm going to give a shout out to my provider. She's a direct patient care provider. And I'm not sure if you're familiar with that, but she opts to take no insurance. And we pay her a monthly fee, but I have access to her any day, morning, noon, and night if I need her for anything.
Yeah.
And she left the whole insurance side of things because of the way insurance companies have been acting lately. So
you know what?
She's not the only one.
More and more. I'm hearing that more and more. But that's more because it's happening. It's more what I've heard is that it's happening more in the upstate area, upstate New York, and the upper New England area. But it's not necessarily common in the Midwest because there's a different population, that kind of thing. But I know that is happening a lot where providers are just doing direct patient care, where they're not doing any contracts. They save a lot of money. There's no risk. It's almost called parlor care. I think that was the term. But yeah, I've heard of that, and that's a big thing. But again, you have to think about a couple of downsides in a larger population versus the smaller areas when you're dealing with that. But that's becoming more common. Yeah.
Absolutely. Absolutely. Well, yeah, I think that there's a lot to be said about this topic. And unfortunately, our time is coming to a close. We've had such a great time today talking, but we will definitely have Robin back on the show. We've had a great time talking to you. How was your experience, Robin, on your first podcast?
This was great. I thank you guys so much. I had so much fun. I could talk to you guys for hours.
I know, right?
I know. We probably need to plan a trip and just have an all-day chat about all of our problems with this stuff.
Absolutely.
And work out some solutions, right?
Oh, that'd be great. I'm on. Just let me know when. I'm ready.
We'll have to plan that. I will have to convince my husband to let me go to the Northeast again because he loves it there. He'll come with me. So
There you
we'll
go.
have to plan something
I'm
like that.
happy to meet you guys in Boston anytime, anywhere. And then I'll have to come up and see you, Maya. I haven't been to Chicago in a bit. As my daughter-in-law would say, and my daughter would say, a minute.
Wait. Don't open the door you can't close, girl.
I'll be there. I'd love to go back to Chicago. I miss that. I miss it there.
Yeah.
I love that.
Well,
What's that? The river trip, the boat trip in the canal. I love that.
Okay,
Oh,
yeah.
yes.
Highly recommend.
There's so many things I gotta try. So many things I gotta try
Gotta
up there.
do
I
that.
haven't tried. That's great.
That
That's
is
great.
so good. Gotta do that, definitely.
Well, Robin, let our audience know, where we can find you, and we're going to put her information in our show notes for everybody. Where's the best place to find you, so they can, have a conversation with you?
Sure. So my email is Robin, ROBIN, at mrsnh.com. Really easy email. And when I respond back to you, I have a little calendar link in my email, so you can just connect there and you can schedule a meeting with me. And our website is mrsnh.com, and you can find out all the different services that we offer, including our software.
Excellent. And as far as education goes and auditing, we are 100% MRS fans. So we are super excited that we get to use your software. It's a game changer for our clients. And we also love education. So everyone keep in mind, we announced this last month, but it is in full force. If you would like a program or a mini course, like a micro education for yourself, we are offering our auditing and coding course. It's really just a kind of transition from coder to auditor. And so it really just gives you the basics of what you know as a coder and transitions you into the auditing world. If you're already an auditor, it's good reminders. So it's a great little way to get some CEUs and also get some extra education for yourself. So go to mdutrain.com. That's mdutrain.com, and check out all of our courses. Thank you for listening today, everyone. And again, thank you, Robin. We will see you next week, guys. Have a good one.
Thank you, guys. Take care.